So the Braden score is pretty broad. So the Braden score looks, I think anyone under 50, like it goes to 21, but anyone under sort of 15 is at risk or at moderate risk, and anyone under 12 is at high risk of pressure injuries. So when you look at the way we look at that, so it asks about level of independence, and level of support is required around sensory, sensory issues, so inability to feel toes, feet. But in our sensory, we also train people to include like delirium. So if they can't respond appropriately or they're not sure where they are, then they're probably also going to struggle. Um, then it looks at people who are bedbound, need support with mobility, who might be either incontinent or very sweaty, because we know that moisture and heat is going to increase your risk of pressure injuries. And then we also look at nutritional factors. So we talk about if you can correct any of those domains, or you can make any of those domains better, so you can improve someone's incontinence, let's say from being very wet all the time to being only wet sometimes or once a shift. That is, although a small change, going to make a big difference in their skin and their risk profile. And then we look at correcting those other domains that we talked about in terms of, well, can we improve their pain management? Can we offload or adjust their splint so it accommodates that foot shape or that leg shape? Can we, you know, and the other one I think, sorry to go back, the other thing I want to talk about is how we talk about to the patient. So in our patient education, we talk about orientating them to being a patient and to communicate, but that doesn't end when you assess them and you put your mattress in place. That is part of every shift. So one of the other things that we do is we have a patient safety rounding protocol, which includes pain management, toileting, pressure care, and looking at drinking and things like that. So, every hour during being awake and every 2 hours overnight, we would visually eyeball that patient. Now, we don't wake them up if they don't need to be woken up, but we eyeball them and go, are they comfortable? Do they need anything? Are they calling for anything? If they are awake, do they have any pain? Do they need to go to the toilet? Can they reach their buzzer? Can they reach their drink? Those sorts of things. Because again, we know those sorts of interventions mean we can pick up changes early. And so that's what we want to be doing is, we're not perfect. Things go wrong all the time, but all patients change all the time. So we want to know what those changes are and intervene as close to that point as possible.
So the patients that we consider at risk are those that have a risk assessment score that denotes that. Now, this varies between our neonate population and our elderly population. We assess everybody. So the neonate population is pretty unique in that they have different factors. So medical devices are their number one cause of pressure injury development, whereas the elderly have frail skin, they have incontinence, they have sensory changes that can all really limit their capacity to tolerate any pressure. And they also have a lot of immobility in both arenas. And so that really puts those patients at risk for the development of pressure injuries.